Hello and welcome to today's webinar. My name is Saumu Lwembe. I work for the National Institute for Health and Care Research. I am very delighted to be chairing this webinar today alongside my colleague Heidi Sarich.
Thank you. My name is Heidi Surridge, and I work for the NIHR as well as a senior manager with responsibilities for community engagement, research inclusion, and shared learning.
Thank you so much, Heidi. So this webinar is actually the fourth in a series of webinars that we are delivering at the NIHR that demonstrate how mutual learning enriches both global and local contexts. These webinar series enable reciprocal sharing of global health innovations in working with people and communities. And this could be in novel ideas, interventions, processes, approaches, or learnings that are aimed at improving health and care research outcomes. The three previous webinars that we delivered explored diverse approaches to community engagement, public members' motivation for involvement in research, and the value of engaging policymakers early and throughout the research process. Today's webinar will showcase how community-driven strategies pioneered in the global health settings are informing service redesign in the UK and achieving demonstrable efficiencies in addressing health inequalities. Our expert speakers will share practical and inspiring examples of global collaboration in action. This will be followed by Q&A from the audience, so please submit your questions. Then followed by reflections from Professor Kevin Munro, who is the Program Director for Research for Patient Benefit Program. We are also joined by Professor Kara Hanson, who is a keen proponent of reciprocal learning. So Heidi, I've talked about expert panelists. Who do we have joining us today?
Okay, we have three colleagues joining us today. Professor Nusrat Hussain is a distinguished NIHR senior investigator and global mental health pioneer whose research into culturally adapted therapies led to the historic decriminalisation of self-harm in Pakistan. His award-winning research, including the NIHR-funded Roshni 2 trial, aims to close the mental health treatment gap for marginalised communities in both UK and low and middle income countries. So welcome, Professor Hussain. We also have joining us today Farah Lunat, who is an operations manager at the Lancashire and South Cumbria NHS Foundation Trust and joint lead of the NIHR Roshni 2 study. She specialises in embedding research into clinical practice to tackle health inequalities. As Assistant Director of the Global Mental Health Research Group at the University of Manchester, she champions culturally responsive maternal mental health and the reduction of ethnic disparities through community engagement and co-production. And finally, last but not least, we have Dr. Matthew Harris with us today. And he is both a clinical reader in public health innovation and an honorary consultant in public health medicine at the Imperial College London. Dr. Harris specialises in translating low-cost healthcare solutions from low and middle-income countries into the NHS. His globally recognised work includes over 150 peer-reviewed publications and 2 textbooks, which promote bidirectional learning to bridge a gap between global health insights and UK health practice. So I'm going to hand you back now to my colleague Samu.
Thank you so much, Heidi. A really interesting lineup of speakers you've got there. I will now invite the panelists. We're going to do something different today. Instead of just diving into the questions, we're going to ask the panelists to deep dive into their case studies. And the first person I'll invite is Professor Nusrat Hussain to present on his project in the RIGHT program and the way community engagement and involvement learning from Pakistan has informed NIHR RFPB and HTA projects in the UK. Over to you, Professor Nusrat.
Thank you very much, and brilliant work on organizing this webinar. I think this is such an important area, important for high-income countries in particular. So today I'm going to quickly scan about maybe the last 10 years of our work on what we have learned. We call it more like 360 degrees learning. And though my work started in the 90s, I came to the UK on a WHO program to learn research because in Pakistan, the treatment gap is huge. Hardly 1 in 10 people receive mental health treatment. And we were of the opinion that we need to address the academic gap to be able to reduce the treatment gap. That brought me to the UK to learn research. I did not write any clinical exams. I was fully focused on research. But what I came across here in the UK was, disparities here also, treatment gap here also. And that is where my work started. There's a place called Cheetham Hill in North Manchester, a very large population of South Asians. But I'll focus on my first is the acknowledgement to all the wonderful people who participated in our studies, who funded it and supported it. And NHR UK has been brilliant. They have been our major funders. So if we look at the latest census data, if we just even look at the South Asian population, it's about 10% of people who are of the South Asian background. Coming originally from Pakistan, my focus was more on the British South Asians. So Roshni trials have been built on initially the work on understanding the social origins of depression, understanding the link between maternal depression and its impact on child growth and development. If you look at, turning the world upside down is a concept which was put forward by Lord Nigel Crisp. He was a CEO of NHS. So much can be learned. And the different 6 pictures are of 6 different projects which we have been doing in different parts of the world, which has looked at maternal depression. A major component of this has been the WHO Thinking Healthy program, which is based on the cognitive behavior therapy principle. Next one, please. My colleague Farah Lunat is going to talk more about it. But one of the learning is about task shifting and task sharing. Our other colleague is going to talk about that more. An example is NHR funded RIGHT project, which was peer-delivered intervention, the Thinking Healthy program, which showed positive results. And the learning has been quite a lot between Pakistan and the UK, bringing into that the focus has to be on the child, and you do not call it a therapy, you call it our participants called it a positive health program. So we have also worked in severe mental illness. We have also done drug trials. There are different concepts about explanatory models of mental illness. So how do you learn from different parts of the world and look at how we can engage with people who are seldom heard? The next one is about bipolar disorders. So the learning has gone to our big base is Nigeria, Jos Nigeria University. So based on our work in Pakistan, there was South-to-South learning. So that led to work in Nigeria. And then it's been funded by NHR is culturally adapted psychoeducation for bipolar disorder. This is about self-harm and suicide prevention work, again, partly funded by NIHR. It has, as mentioned, led to decriminalization of self-harm in Pakistan, and also it started with the Sustainable Development Goals that the parliamentary lead reached out to us. So this is about working with the health minister, and so we were able to write the first aid guidelines with colleagues from the UK. We were able to draft the mental health policy. We have also done substance use policy. So it has again going to be have a major impact in the UK. Is because self-harm at one time, it was that the rates of self-harm and suicide were much higher in the British South Asian women. So that work which we are doing, it's one of my PhD student here in the UK has done some qualitative work and discussion groups. And thank you very much for your attention.
Thank you so much, Professor Nusrat. And one of the things that you were saying there was the importance of framing. When the people you're working with said, don't call it therapy, call it a wellness program. Framing is very important. So thank you. We shall move on now. I invite Farah, who is going to speak more on this and share the learning from Pakistani and on community engagement and cultural humility within maternal mental health. Farah, please.
Okay, so brilliant. What I'll be doing is just building a little bit on what Professor Hussain has mentioned there, specifically about the Roshni trials and how we kind of had that global bidirectional learning. So just starting with my key message here, I guess, is that we speak about this a lot, and there's a lot of kind of NIHR tools and resources, but just really highlighting that research really needs to be developed with the communities and not to the communities. And that's some of the examples that I'll be giving. So earlier in my introduction, that was kind of Lean took on, but I'm very fortunate to kind of have a role where I have an operational role within an NHS setting, but also a role as a global mental health academic researcher across different organizations. And I guess the most powerful CEI principle that I've really learned over the years has been to really center that power sharing, specifically when we're speaking about South Asian contexts, to really think about trust and to think about cultural humility. And I've put there that I'm a PhD student because I'm in the final couple of weeks of centering a PhD, which really focuses on cultural humility. And I guess that was something that I learned across my career. When I first started on Roshni as a research assistant, I very much spoke about cultural competence. And I guess that shift to cultural humility has really come from the community, with the sense that competence assumes that we can master something, whereas humility really encourages us to be constantly reflective, to have an open mind, to be curious. And that really shapes how you engage with the community, because if you have the lens of cultural humility, you're able to engage with the community in the non-judgmental and respectful way that they need you to be able to, so that we can improve access to care. So just going on a little bit more in terms of the global principles that transformed some of the recruitment and retention activities in Roshni 2. As Professor Hussain said, it was really built on the learning from the Thinking Healthy program led by Professor Atif Rahman, and also the Learning Through Play program in Pakistan, and also some work done in Nigeria. Some of the key things that we learned from that was really around starting that engagement long before you start recruitment. I think some of the things that I've learned is, even now in research trials, a trial will start, it'll have been, a whole grant application's gone in, the budget is set, and a couple of months in, the team will come together and say, we need, our sample isn't representative, what do we need to do? What we really need to do is start thinking about that community way before we start the study activities. And this is through family engagement, through faith leaders, and through trusted community spaces. What we did in Roshni was we went out into the community where women already were, rather than expecting them to come to us. That included doing chai with Roshni sessions, so have a cup of tea with us, an informal space, and we'll have a chat with you about maternal mental health, about research, and about why we do research. And some of that is having some really open conversations in the community to say, we acknowledge that maybe things haven't been right to date. We acknowledge that you've not really understood what research is because the terminology doesn't make sense to you. We're using terms that don't relate to you. So what can we do differently? And really making the community be a part of that process so that they shape not only the intervention delivery, but they shape things from a very early stage, including the ethics applications to the grants. Again, seeing families and faith leaders as an essential partner and not as an obstacle. I think one of the things that I guess we've really learned from work in Pakistan, especially, and from speaking to my colleagues in Pakistan, is that for a lot of South Asian communities, faith is the center of their identity. And if we're trying to develop pathways and improve care, how can we then disregard a key concept and component of a person's identity? So we need to come together with the family members who play a crucial role in people's lives and also with faith leaders. Bilingual and culturally grounded communication. Again, all of our materials were translated into different languages. Again, with the recognition that not everybody speaks the language not everybody can read the language that they speak, but to be able to see something that was in their language gave them that sense of familiarity and again, built trust in the research team. Lived experience being an expertise and really recognizing that people with lived experience needed to become a part of our research team and really have a voice and what meaningful lived experience really looked like within this community. And like Professor Hussain briefly mentioned around the Thinking Healthy program, this was a delivery of a cognitive behavior therapy intervention, culturally adapted, but delivered by community health workers in Pakistan. And that again demonstrated a recovery in 3 out of 4 women. So it was a learning for us in Roshni that we could deliver the intervention with non-specialist workers. We didn't need to go into NHS services with high-level CBT therapists. We could look at something that was more low resource, cost effective, and also built capacity and skills in the community. So some of these strategies are there that I've already described. The one example that I really wanted to focus on was just family inclusive consent. And that was basically an acknowledgement that for us, we went into the community and and our lived experience experts really showed us that in order to really engage these women and allow them to be participants in the study, we needed to engage with the family in a more wholesome and more meaningful way. And that was because a lot of women in South Asian communities include the family in their decision making. Decision making is a collective decision. There's husbands involved, there's mother-in-laws, father-in-laws, grandparents involved. And we wanted to really recognize and respect that. So we did sessions where we would sit with the family, we would speak to them about consent, we would explain good clinical practice from an NIHR perspective and why we needed to take consent. And very often we were doing consent within a family session together with a family member, not just with the individual. And again, that's a recognition that sometimes we need to adapt our principles, and that may not just be the methodology of our research. It extends to things like our ethics and our governance and how we're operating. Traditionally, we've always done consent as a one-on-one with the participant, but where we're working with cultures such as South Asian culture, we need to recognize what's respectful to them. And again, framing the positive health program, which is our culturally adapted intervention for this study, around the well-being of the children, around the well-being of the family, around maintaining relationships within the family, so that it was seen as something positive and really helped us to be able to tackle that stigma. So these are just some of the examples of community engagement. Like I said, we did lots of chai sessions, we did lots of engagement with counsellors, radio, TV. And what this really made possible, I guess, the impact of this community engagement and involvement is that we were able to screen over 4,000 South Asian women to the study. We randomized over 700. This is one of the largest maternal mental health trials in an underserved population to our knowledge. And achieved during a period where the NHS services, we are still having meetings where we talk about lack of access, we talk about a lack of representation in our data. So we've demonstrated that communities do engage when we engage differently, and the issue isn't willingness, it's our approach as academics, as researchers, as clinicians, and that's something that we need to be reflecting on. I won't touch too much on this, but this just gives you a very quick snapshot of the fact that the barriers across both my learning in Pakistan and the UK are very similar, sometimes worded a bit differently, but the barriers remain the same. And I guess one thing that we need to really acknowledge is that women will engage when you're able to make them feel safe, understood, and respected in this study. And that then, that learning applies to not just South Asian women in research, but more broadly families and underrepresented communities across the UK and other countries. And why co-production really matters, especially in this context, is because we're looking at something around power sharing. In South Asian context specifically, there's a lot of work we need to do to really tackle stigma. And when you do this level of co-production and the women become central to the research and families start to shape every step of the research, stigma loses its power. And that's one of the most powerful things that co-production allows you to do, is to be able to take away the power of stigma in a community and allow families and community members to become allies in your research. So just to end there, when we share power, we listen deeply and we work with communities. We don't just improve our research, we transform our access, trust, and our outcomes. Thank you very much.
Thank you so much, Farah. Couple of tweetable comments you just made there. Communities do engage when we engage differently. Start engagement long before you start the study or trial, and family and faith leaders as partners, not obstacles. Very strong messages. Thank you for that. I shall now invite Dr. Matthew Harris to give us some case study on bidirectional learning in action, showcasing this real-world example of adapting a low-cost global solution for the NHS. Dr. Harris, please.
Well, thanks so much, Samu, and so lovely to be here sharing some thoughts with you and reflections about this. I think the first thing I would say is that there's just so many opportunities to learn from low and middle income countries, whether it's on this particular topic or in surgical innovation and other sorts of innovations around frugal and low-cost technologies. I think whether it's in obstetrics, orthopedics, or plastic surgery, cardiology, neonatology, we've seen so many fantastic examples coming out from no middle-income country context that the opportunities are absolutely manifold. The example I'm though going to talk about is actually around community health workers as well, much like the previous speakers. Thinking about it, not so much as what can community health workers do, but why on earth don't we have them in the first place in the UK as part of an infrastructure that underpins our entire primary care system, like they do in many countries around the world, Pakistan and Brazil and Ethiopia and Nigeria. Many countries, community health workers are literally the bedrock of the healthcare system. So whilst it's very important, we have a lot to learn about what community health workers can do. I think we've also got a lot to learn about how do we actually transform our healthcare system here in the UK so that it's actually based on a foundation of community health workers, an army of community health workers like they do have in many of those sorts of contexts. I draw my experience predominantly from having worked in Brazil in my mid-20s for about 4 or 5 years as a GP in a rural, very poor, impoverished rural community in the northeast of Brazil. I'm happy to say that fast forward 25, 30 years, we've now got a very, very healthy memorandum of understanding between Imperial College and Fiocruz, their preeminent research institution in Rio and Manaus and other parts of the country that is very, very mutually beneficial. We're at the moment going to be embarking on a program to actually develop resources around climate resilience and climate change for community health workers for both contexts. So we're actually developing material and training and curricula that will be suitable for community health workers in both the UK and Brazil and beyond. And I think that feels like a very important thing to have developed because of that co-partnership, co-production, co-involvement, mutual benefit, working together, as well as learning from each other at the same time. But the reason why I think that the Brazilian example is so interesting is that they actually have an army of community health workers that covers now nearly 75% of the population. There are 400,000 community health workers. These are the 4 that I worked with back in the late 90s. And they're recruited from the local community. They work within defined territories that they are responsible for individually, and they visit and door knock every single household within those micro areas of about 150 households at least once per month without any agenda at all. It's across the life course, across health and social care, dealing with as breastfeeding all the way through to immunization uptake and screening uptake, mental health support, depression, loneliness, social isolation, chronic disease management support, adherence support, you name it. It can be across absolutely anything. And for me, what I found fascinating was that this is an infrastructure through which you can deliver almost any public health policy you like direct into the door, direct into the home, because community health workers are such trusted members of the community, building those relationships with those residents all the time. So this proactive, relational, continuous type of care is transformational relative to how that we do things here in the UK. But it's been a particularly hard journey. So over the last 20 years, what we've predominantly heard up until more recently is actually, but it's Brazil, and what can we possibly learn from Brazil? So I think when we think about reciprocity, reverse innovation, when we think about learning from low middle income countries, we've really got to actually begin by addressing what might be some of the knee-jerk reactions that we might have here in the UK to learning from some of those contexts, because it is not necessarily places that we're yet particularly familiar with. And you really have to work through it. But I have to say that work through it we have done. And over the years, through lots of effort through the National Association of Primary Care and colleagues all over the country, we actually now have, just in the last 4 years, community health workers being delivered in over 25 different locations. So it's not like in Brazil where we have 400,000, but it's a start. And we actually think that we're actually going to be looking at increasing the numbers of community health workers throughout the NHS and primary care over the next few years. Former head of NHS England's Director of Health Inequalities, Bola Awolabi, called it these a game changer. And we are about to embark on reporting our cluster randomized controlled study in the Westminster context, where we've been able to deploy community health workers at random to see what the impact is. So very exciting. In addition, how it's influencing policy. So this particular innovation, if you like, coming from the Brazilian system, first mentioned in the Fuller Stocktake report, then also in the House of Lords report, and more recently in the 10-year plan. So we're really starting to see a little bit of a shift in terms of appetite for delivering a community health worker infrastructure like we see in some of our partner countries in the Global South. But it requires an awful lot of work and effort. As our colleagues have already mentioned, the amount of research that needs to go into this is actually not insignificant in order to be able to change hearts and minds and generate evidence base. And so we've been doing an awful lot of that over the last few years in order to be able to identify what works for who and why, what is the impact on immunizations and screening, what are the implementation issues around deploying community health workers in the UK context, what's the impact of the role on themselves, what's the impact on residents? How do we deploy them through training around dialogic approaches? Is the training effective? Lots of work needs to go in to actually sustaining this model as part of a transformational change that can't be underestimated. So I'm just going to end with just a couple of reflections over the years. With a shameless plug for my book, Decolonizing Healthcare Innovation, that goes into all of this in a lot more detail and many of the opportunities around learning from low-income countries. The first is that I think the opportunity for learning from low-income countries is absolutely considerable and urgent. Had we had an army of community health workers like Brazil, Nigeria, and other countries have, when COVID hit, we would have done much better than we actually did do. So I think we really are late to the game in terms of learning from our Global South colleagues. The second thing to say is I think there are lots of entrenched systemic barriers to doing so. A lot of it comes down to funding, but also cognitive barriers, cultural barriers that actually need changing around our perceptions. The third rather, is that there's a difference between individual learning and institutional learning. I worked in Brazil, have a huge affinity to it, saw it in practice, worked with it for 4 years, therefore understood what the opportunities were back in the UK. Institutions don't necessarily work like that. So we have to actually find a way of actually tapping the individual knowledge that people get from working overseas and embedding that into institutional learning in a more efficient way than has been, at least in our experience. And then the fourth and final point I'd like to make is around the NIHR infrastructure awards, like the applied research collaborations. All of the research I just detailed on the previous slide could only really have been possible because we were funded by the NIHR as an infrastructure award to work on applied health research and health services research in the UK on topics of our choosing, rather than actually applying for specific grants on specific things that are of particular interest in a specific way. And I just think we underestimate perhaps the importance of these infrastructure awards and just how beneficial they can be to pump prime what might be initially quite challenging or controversial or difficult, not particularly palatable projects, but in a way that can be supported and sustained until we get the evidence base across the line for it to spread, scale, and sustain. And I'll end there. Thank you so much.
Thank you so much, Dr. Harris. Very interesting reflection there. And one of the things that I really liked about your presentation was the intellectual provocation that you started with at the beginning. Why don't we have community health workers as part of this system in the UK? Why don't we indeed, especially in the light of the recent policy change around integrated neighborhood health? So that's really interesting. And that in itself will launch us to the questions that I have for some of the panelists, for all the panelists actually. So obviously the discussion here that we've had, it really is, in my view, centering around challenging this traditional view of knowledge transfer and embracing a model of reciprocal or bidirectional learning. So in your expert opinion, what is the single most critical mindset shift that UK policymakers, researchers, practitioners must adopt to genuinely value and apply innovations and CEI principles originating from Global South. Yeah, shall I start with you, Professor Hussain?
Okay. I think one of the things which I see here in the UK is the service providers, the researchers, and policymakers really are not talking to each other. Is if you go out, so people like me from the universities would go and go to the trusts, primary care, recruit people, of sometimes don't even share the results. The information, there's limited. We've had NHR policy grants as well, but that needs to bring policymakers a bit closer. So if I talk about Pakistan, if I talk about Nigeria, we are able to work very closely with the service providers and the policymakers, and we are able to engage, and that leads to a real change to the end users. So in a very short time, we have been able to do that. We have got 3 demonstration sites, which in combined has a population of 5 million, most affected by the floods. The health minister has funded, which used to be called the Increasing Access to Psychological Therapies program. And that is going to really at the end user routine care. So those conversations maybe we need to bring in. And obviously, the people with lived experience have got to be at the heart of it.
Thank you so much, Professor Hussain. And perhaps the same question for you, Dr. Harris. And I know you reflected some of this in your presentation already anyway, but really thinking about that mindset shift, because you talked about some of these issues are cultural. So what is that a critical mindset shift that needs to happen for us to be able to see some of these learnings coming through?
Can I give you 2?
Right, okay.
Is that okay? To be cheeky, but I think it's the 2 things. The first thing is that it's okay to not be okay. That we in the UK are not okay. We don't have all the answers. Our system is pretty broken. It's inefficient and it's fragmented, and it's not helping all the people at the right time in the right way. So it's okay to say so, first of all. And I think there's a little bit of a superiority complex we sometimes have, unfortunately, where we don't like to say it or admit to our problems, at least out loud. And that has to change, because until you know that and admit that you've got problems, you can't really accept solutions. So I think that's the first thing. And then the second thing I'd say, and there's more, but I'll just stop at 2. The second thing I'd say is that there's much more, and I think, Farah, you put it beautifully. There's a lot more that we have in common with many countries around the world than divides us. The problems are the same. They might not look the same at face value because we focus on things like, the way buildings look or the way schools look and things like that. But actually, the mechanisms are the same, right? People just need a bit of support. People have families, people are parts of communities, they might need information, they might need helping with something. That's the same in the UK. It doesn't change. It's just the language might be different, but the issues are the same, absolutely the same, and the ways of solving them are the same. So we need to do 2 things: know that we're not okay, and secondly, know that there's a lot we have in common with countries we don't think we do.
Thank you. Farah, can I check, do you have anything additional to add to that question?
No, I guess, yeah, 100% would agree. And I think that's, when you look at the affairs happening across the world, there's so many examples there's so many things that really kind of unite us. And I guess that's something we speak about when we talk about working with communities, is that when we talk about cultural humility and adaptation, we want to celebrate the culture. We're not saying we want to take it away and, make you fit into the systems that are in our NHS services, for example, and pathways. We want to really understand what your culture means to you and how we can then bring that forward into your recovery and into your intervention deliveries and so on, and really be able to champion and celebrate that. And that's, I guess, something that we all need to also acknowledge, is that we need to be more open to wanting to do that as well. Sometimes, we're too fearful of wanting to ask questions, and some people have sometimes just said to me, they'll be health visitors or midwives, I don't understand why a woman is doing that in her home at all. And it's like, I'm so glad you asked, because that will make the biggest difference to how you then provide care for that person. So I guess, yeah, a key lesson would be for us all to be more open, be more curious, and be more brave to ask the questions that we need to really enact that change.
Thank you for that. Perhaps, Professor Hussein, if I can ask you perhaps an additional question. So you've told us, obviously, you've worked extensively in the mental health treatment gap in LMICs where resources are at their thinnest. So as the NHS faces its unprecedented, wow, resource constraints, what lessons in frugal innovation or community-led task shifting can the UK learn from Pakistan to ensure quality care doesn't always require massive infrastructure?
Yeah, I think one of the things which is important to look at with this learning is it's not about doing more with less. I think it's about doing better with what we have already. So when we talk about, these cuts and those, we have got wonderful resources with regard to NHS. So learning from there is, working together and try and bring a change. So I gave you the example of 3 demonstration sites. So we have a commitment from the health minister that it would be, go up to 50 million population of Sindh province if in the next 2 years it does not have huge additional costs. So I think we also need to look at one of the unfortunate things, which my focus of research is more ethnic minorities in the UK. And when I came in the 90s, what I saw, which, got me doing research in the UK was, their needs are far more. And unfortunately, if we look at dollars and cents also, South Asians like me are more likely to have heart disease. People like me are more likely to have diabetes. People like me are more likely to die younger. People like me are more likely to have complications. So the NHS is spending, but we look at how do we engage and look at. We are said to be that we do not engage with the community cardiac rehabilitation program and those. I think a lot can be learned is the engagement. There's no difference in science. Um, you know, um, Matthew and Farah has also talked about similarities. So it would be looking at how do we engage and look at. A lot of our time, which Farah has spent would be, engaging, going out there, spending time in the gurdwaras, in temples, is looking at. Um, with African Caribbean population, we are engaged with the Black Church also. So looking at how do you work on the great resources which are out there in the community also, and try and look at, we do not kind of insist on people fitting into certain boxes and be rigid about it. So that a lot of work in Roshni trial was engaging with the the governance group also was. Farah talked about taking consent and involving um, the the husbands and the mother-in-law and those. So I'll give you an example of there are some places where they offer routine, interpersonal therapy or cognitive behavior therapy, whoever presents after self-harm. If we look at South Asians in the Northwest, the rates are quite high, more in young married women, but they present, and the one is, if you do not involve the family, is less likely to. So they are more likely to drop out if they even attend the first appointment. So we need to look at how we can engage and work through. So all our suicide prevention work in Pakistan, where till recently it was a criminal offense, in Muslims it is considered to be haram. So how do you navigate all that is working through and still be able to deliver the one of the largest trials to time and
Yeah.
target. So
Yeah.
work.
Thank you so much for that. I've got many other questions, but I'm also conscious that our audience are really keen for you to respond to their questions. I shall now bring in my colleague Heidi to moderate those questions. Please, Heidi.
Okay, it's been lovely listening to you all. There have been a few submitted questions, quite a lot about community health workers, funnily enough. So one of our first questions was around have you found any drawbacks to implementing the community health worker model in the programs that you've undertaken so far? I think it's more of a question for Dr. Harris. And if so, how have these been overcome?
To answer that question, we have to understand the context here in the NHS and primary care, which was very different when the Brazilians started their community health worker model back in the mid 1990s, where there was no really established primary care system to begin with. So here in the UK, there is a very, very established primary care system. It's also not deployed universally in the sense of geographies like it is in Brazil. You have catchment areas which are different. And so in primary care, GPs attend a list, they don't attend to a population. Right, so it's a very, very different focus. So one of the main drawbacks we had with deploying community health workers here in the UK, which is based on a geography rather than a list or a caseload, is having the system change around it, right? So they're not used to that way of working. So we've had to, whilst it's a very simple model in principle, community health workers door knock 150 houses in a defined geography at least once a month and don't arrive with any agenda. They just ask what matters to the family and help them with whatever it is integrated into the rest of the system, signposting, giving information, all the rest of it. The system needs to accommodate a role like that. And so it's been extremely challenging. We're getting there, but it's been extremely challenging helping, for example, primary care grapple with the idea of community health workers entering information into the electronic patient record. Or having social workers be able to contact the community health workers because they know that they look after Mrs. Smith at number 23, or having the acute trusts be able to, at a glance, know which community health worker is looking after the patient they're about to discharge. That's about system change. It's not a drawback. It's about the challenge of implementing change within a really, really complex adaptive system that doesn't really inherently want to. The thing is, the benefits for the community health workers are so apparent and so rapidly gained and so visible by everybody who comes across them that we're starting to see that change in all the many, many localities that we're now in. So it's definitely worth it, but it is a challenge getting to that point.
Thank you. Thank you. Nothing is ever simple and straightforward, but your perseverance is greatly appreciated. I mean, you're in the 10-year plan, which is in that respect, which is absolutely fantastic. Most of our questions are around the community health workers. If I could pose one more, I think, in probably not quite so provocative as a way as some of the questions that have come through, and a little bit more about obviously community health workers in a lot of countries are quite popular. They have a lot of work. They're asked to do huge variations in their role. I mean, I've even heard stories of research groups offering sort of T-shirts or the best free water bottles to get people engaged, the community health workers engaged in their research. How do you think for a workforce that can be overloaded and there can be an equity issue, how can we make sure that these people globally are protected?
Is that to me, Heidi?
I think it's an open question.
Okay.
But
Shall
yes,
I try in super
please.
fast? I'll be really quick. Well, I think the community, I would refer everybody to the work of the Community Health Impact Coalition, CHIC. They do incredible work advocating for fair, pay to start with for community health workers globally, fair pay at that respected, professionalized role, which is absolutely right and proper. I think sometimes we think about community health workers wrongly, which is a sort of a poor solution for the poor. They're not. They're incredibly sophisticated, incredibly essential part of the healthcare economy. And they are the only ones that really know the community. We as clinicians, perhaps we stay in our clinics, we don't know the community. Can't pretend to. They're the only ones that actually really know the community. So they are a very, very specific and unique role. So to tap into one of the other questions I think I saw in the chat, which is that actually you have to, here we're in the UK, follow the Brazilian model by paying community health workers a fair, respectable salary that is compatible with cost of living. It's essentially Agenda for Change Band 2 or 3 for those of you that will be familiar with that here in the UK. They get supported, clinical supervision, they work as part of a team. They're not just sort of out there, and they get on-the-job training throughout the course of their work, as well as initial training too. So it's a supported role, and that has to be absolutely an essential feature of the role as well, because the sorts of things they have to deal with on the ground are very, very draining and actually very, very complex.
Can I make a comment on this?
Of course.
I think like somebody has mentioned in the chat also about avoiding burnout. And that is very much in Pakistan, they're called, most of them are women, is called a Lady Health Workers Program. So anything and everything comes to the lady health workers, that they'll deliver this, from vaccinations to therapies to everything comes to. And that is important to look at, that there's no burnout. We should also look at what there are people who are already available and within our health systems. Are they able to take some of the kind of roles which community health workers are maybe doing in Brazil, and instead of maybe adding a new cadre, looking at what do they really do? One of the biggest thing is the trust they enjoy of the community, of the population. So while at the same time looking at how do we look after them. So this is something we are trying to look at in Pakistan, how we have worked through. We have got another NHR right project on. We are looking at breast cancer and depression in women. It's a very large trial. We are reaching to up to 100,000 women with breast cancer, and we are randomizing 26,000 women with breast cancer and depression. So we are working very closely with the lady health workers because they know is. And the other thing which we are wanting to do is increase the awareness about the breast cancer, because there's a concept of sharam, or what is it called in English? Sharam is the for the women are hesitant to talk about breasts, and and when you're increasing awareness, how do you do that? So we're doing a small project in the Northwest also about breast cancer in South Asian women, because unfortunately, by the time they present to NHS services, there's quite a delay. So there are far more complications and those bits. So coming back to the community health workers, they're brilliant. They're able to work with us. And how do you look at that it fits into their, routine work? They are able to do that.
Thank you. Now, I'm conscious that we want to go to our program directors. Samu, did you want to?
Yes, just checking, Professor Hanson. I know in our conversation previously, we know this is an area that you really are very passionate about, and wondered whether you had a question for the panelists.
Thank you. Thank you very much, panelists. I thoroughly enjoyed all of your presentations. I guess one of my questions is, are there limits to this kind of transferability? So, we've talked, so in a way, Professor Nusrat and Farah, you talked about how that kind of transfer between communities that have shared traditions and shared institutions and shared culture So that seems like something that is be fairly easily transferred. But what are the underlying principles that should guide our thinking process around what sorts of interventions or research approaches or engagement approaches are likely to be transferable across wildly different contexts?
I think those principles are already there within the NIHR, but how do you engage with the population and who is going to do that, and how do you negotiate the right balance, what you can do. I'll give you an example of I work with the early intervention and psychosis services. There's a concept of jinn and black magic, and those even with third generation. So how do you negotiate those models of their working that we feel comfortable in going? I'm a Muslim, but I feel comfortable in going to a gurdwara or a temple or a church. How we are able to, for people like us, to be able to do that. In central Manchester, I was closely working with the Black Church as part of my clinical practice. And I think we need to look at how do the clinicians, service providers, and researchers can really work together. This thing I tell all my colleagues, they say, sometimes say we are too busy clinically. And I speak to them about when I started research, I was a full-time consultant psychiatrist in central Manchester. So I talk to them about that the research is going to help them and not improve the outcomes, that is my experience. But going out and listening, that somebody used a very nice word with them, our colleague, seldom heard population is going out, principles are the same, which we have in the NHR. Principles are the same.
Really quickly, Cara, thank you so much for the question. I think in terms of how we learn, I think it's important to maybe remember this sort of double loop learning to learn thing that's important. So oftentimes in our work, we've found people just sort of saying, can we just sort of stop mentioning that it came from Brazil? Is that okay now? We've done that enough. And I really insist on not doing that. I really insist on retaining the legacy of having learned from Brazil because it has such an important firstly, there's the hereditary of it. It came from Brazil. I mean, why deny it? But also, there's a lot to point out that's what we need to learn. Actually, is that we've learned from Brazil, not just around community health workers, but that it's possible. So I think in terms of your question about limits, we must not have limits to an ongoing recognition of where we've learned from.
That's really well responded, I think. Farah, can I just get your thinking here for 30 seconds? What would you want to say to the audience as an immediate call to action that everyone should do based on the learnings they've received today?
I think, treating the community as partners and building community engagement into the foundations of our work. I think just leaning in on what Dr. Harris said there as well, we sometimes put a lot of operational barriers and we don't do a lot of thinking outside the box. I guess we try and think that innovation needs to come from specialist places, but we know that learning and really valuable knowledge can come from the community itself. And we can, if we can learn from low resource settings, we're in very privileged positions of where we are in the UK, and we can deliver a lot more if we're more open to changing our mindset to think differently. So I guess that would be my call to action, is to listen, adapt, and share that learning with the community.
Thank you so much, Farah. Listen and adapt. And if you are anything like me, these discussions are really enjoyable and we can go on and on. And it's sad because I've got so many questions, even from the audience as well. But time, unfortunately, has run out on us. I'd like to invite Professor Kevin Munro, please, to offer your final reflections.
Thank you, Simon. I've been writing furiously. So I hope you'll excuse me if I've not captured all the points, and I hope I'm able to read my own writing. But there are a few, I think, take-home messages I have from this, and they group around 1, 2, 3, 4 different points. One of them is understanding and appreciating the benefit of the shared learning and the importance of it. And I think we've heard that beautifully today from all these presentations. The importance of bi-directional learning, of things moving forward and then reverse innovation. And I think it's good for us to pause and think about this superiority complex. And it isn't just one way things flowing out to the UK, but it's dynamic and there's important things that we can all learn and share from each other in multiple settings. Because as Farah said, a lot of the challenges are the same that we're going to be faced with. So it's been great to hear about real examples where there's been a contribution to knowledge and practice, and it's moved from one global south country to another, and then somewhere along the way it's come back to the UK again. So I think it's good for us to appreciate that and remember that the UK is not perfect. The second message, I think, is about what works, what is appropriate when we're working with communities and patients. And I think this is not a quick fix. If we want to have an equal and lasting relationship in many things in life, we have to invest into it. So I think building trust, we've heard a lot today about the community health workers and trying to avoid burnout in the population that we might always turn to, but building trust and an understanding with the communities and being in an active partnership, I think, is at the fundamental core of all of this. And it would be so easy to tick a box and fall into tokenism. So really having an active and a shared partnership. The third point I wanted to make was, why is it important that we have these webinars, and why is it important that we share this learning with others? And one of them is NIHR is at the vanguard at a lot of these developments: community involvement, patient involvement, research inclusion. So it really pays that we spread the news on behalf of NIHR and that what we're trying to do in the UK. We're not the only ones and we're not necessarily the best, but we are working hard and we do embrace these activities. If we don't share it, it means the learning is limited to the few people on this call and it doesn't spread out, and others don't benefit from the learning and from the experiences. And also it means we have a limited pool of resources and we want a bigger bang for our buck. So we don't really want everyone to go out and keep inventing the wheel if there's already experiences out there that we can all benefit from. So I think the webinar today is one example of how we share it. But my final comments is really thinking about, but how can we build on what we're doing today? And I was wondering as I was listening, is there a role for all the NIHR domestic research funding programs to promote and encourage bi-directional learning? And I guess the question would be, how do you get it on the radar? But each of the programs has guidance notes, and it might even just make a start to get it on the radar of every applicant if they see in the guidance notes that there's a comment to bi-directional learning and maybe a link to this webinar so they can go away and hear about possible examples. And the final thing is, and I think Matthew was touching on this at the end, was should bi-directional learning be reported in our dissemination? So NIHR are keen, and the policy is that patient involvement is reported in all our peer-reviewed publications, and it depends on the nature of the publication and what the journal will allow. But at the very least, we expect a couple of sentences, one saying there was PPI and this is what the role was. Perhaps more importantly, a sentence reflecting on what the active contribution was and what the benefit was. But what prevents us from slipping in a sentence about the legacy and the origins of the work we've done? And it comes back to, I think, Matthew's point about legacy, remembering who we're learning from, and maybe just remind us about this superiority complex that I think we're likely to have. But that would be my rather hasty comments to take away. Thank you.
Thank you so much, Professor Munro, and really very practical call to action just there. Things even for us to consider at the national level. Thank you so much for that. And thank you everyone for joining us today. And we want to thank especially our panelists for your presentation and for your sharing as well. And we do hope you have all taken something out of this session today and that this has inspired you to enhance your approach to working with people and communities and service design and addressing health inequalities. We look forward to seeing you again in the next iteration of our series. So yeah, thank you so much. Go onto our NHR website for our community engagement and involvement pages, and we shall communicate future sessions as well. So thank you all.